My name is Howard Levitin. I'm an emergency physician in Columbus, Ohio at Ohio Health Doctors Hospital. I am the research director and core faculty of our emergency medicine residency program at Ohio Health, and I'm also the physician advocate and the physician champion for our substance use program at our hospital. This module is going to cover substance use disorder risk factors, and I'm also going to talk about validated screening tools. So the objective of this module is to enhance your understanding of substance use disorder and the risk factors associated with developing this disorder. In addition, this module will introduce you to a variety of validated screening tools that you can use and apply to your practice. Let's start with a simple case study. This is Mary's third visit in 2 months for painful decayed teeth. 2 years ago, she had excellent teeth, a great complexion, and spoke about going to college. She's now much thinner and anxious appearing, with several infected teeth and sores on her face. Her teeth are blackened and decayed, with several dental abscesses and widespread periodontal disease. When asked, Mary reports that she's fallen on hard times, rinses her mouth with well water, can't seem to get off the sugar. She reports that her dental pain is now a 10 out of 10. She needs antibiotics to clear up this infection. She's been unable to sleep at night and can't go to work because of the pain. Doctor, please help me. I'm in so much pain. A substance use disorder is a condition that affects a person's brain and behavior, leading to an inability to control the use of legal or illegal drugs or medicine. Substances such as alcohol, marijuana, and nicotine are all considered drugs. When you're addicted, you may continue using the drug despite the harm that it causes. Drug addiction can start with experimental use of a recreational substance in social situations, and for some people, the drug use becomes more frequent. For others, particularly with opioids, drug addiction begins when they take prescribed medicines or receive them from others who have prescriptions. So the criteria for substance use disorder begins with this craving to use the substance. Morning, noon, and night, you're constantly having a craving to take the drug. But you want to stop the drug. You want to try to cut down, but you simply can't. And to get the same effect, you begin using higher and higher amounts for longer periods of time to try to get the high and offset the lows. As a result of the addiction, you start neglecting parts of your own life. You neglect relationships. Relationships become more difficult. In the end, you start using substances even when it puts them in danger. We see people coming in with skin abscesses and other related infections from use of substance use, but they simply can't stop using. The same thing is with alcohol. So chronic substance use disorder in many ways is like a chronic disease, such as heart disease and lung disease. Each of these conditions disrupt the normal healthy functioning of an organ in the body. Each has serious harmful effects, and each are in many cases preventable and treatable. If left untreated, however, they can last a lifetime and may lead to permanent disability and death. So as clinicians, we are aware that clinical relapse is part of the natural clinical course for most patients. Individuals stop taking their prescribed medications, they don't follow a recommended diet, and not uncommonly, they return to smoking. The chronic nature of addiction means that in some people, relapse after an attempt to stop is part of the process. The relapse rate for those with substance use disorder is similar to what occurs with other chronic diseases such as hypertension, asthma, and diabetes. And based on the graph, about 40 to 50% will have an episode of relapse, and some of them have multiple episodes of relapse. So if patients stop following their medical treatment plan, they are simply likely to relapse. Relapse, in my mind, is not a failure, just an opportunity for course correction. So chronic illness is typically thought of as a disease of aging, typically peaking in one's later years. The underlying disease process is insidious, often begins when an individual is actually young, but goes unrecognized until one approaches middle age and older. Once symptoms appear, the healthcare system suddenly works diligently to manage the illness rather than intervening early to prevent it or to delay it from occurring. And as you can see from the graph, every 10 years or so, the incidence of chronic disease goes up. So in general, although we look at substance use as a chronic disease, Compared to most, it's a disease, most chronic disease affects people in their elder years. But substance use disorder, unfortunately, disproportionately affects those in the prime of their life, at a time when life stresses, peer pressures, and simply the desire to fit in and the early signs of mental illness begin to manifest. Treatment at this stage is much more difficult with a lower success rate as compared to screening and intervening during one's adolescent years. When you look at the graph, you start seeing that diseases, mental health diseases of youth, depression and anxiety go up and start at a very young age. And it corresponds with that peak in those diseases with a peak in using substance use. So you start realizing that identifying behavioral health and mental health issues at a younger age and intervening before they turn to drugs increases the likelihood of success. And so when we talk about chronic disease and acute disease, the reality in a chronic disease is while the overall morbidity rate of chronic disease has been reduced or leveled off over the years, that's fairly impressive. But when you compare that to substance use, the mortality rate is going up excessively. And as we'll cover in a few more slides, much of that increase in substance use, overdose, and death is due to the widespread availability of fentanyl and the availability of polysubstance use. So as clinicians, we are aware of the ravages of the drug epidemic. Drug overdoses kill more than 64,000 people a year, and the nation's life expectancy continues to fall as a result, unparalleled by any other developing nation. This epidemic is not only destroying individuals, but it's tearing apart families, overwhelming foster care, the healthcare systems, drug treatment programs, exacerbating economic inequalities, and pulling apart the fabric of our communities. Opioids in particular reach every part of society, blue collar, white collar, everybody. It's nonstop. It's every day, and it won't get better until each of us takes an active role in stopping this epidemic. So you see from this graph, opioids are the primary contributor to overdose deaths, either individually or in combination with other substances. According to data from the CDC in 2023, deaths due to psychostimulants, for example, methamphetamines or cocaine, are up 7-fold since 2015. So as you see from this graph, no doubt that the combination of drugs combined with opioids is the number one reason why we're seeing such a huge increase in deaths related to substance use disorder. In addition to overdose deaths, the drug epidemic contributes substantially to other chronic diseases such as chronic liver disease and cancer, polysubstance abuse, psychiatric harms, infectious diseases such as HIV, AIDS, and hepatitis. And sadly, the United States leads the world in drug-related mortality. In fact, the mortality rate nearly doubles what's going on in Australia, several times what occurs in Canada, and nearly 4 times the mortality rate is compared to the United Kingdom. So the United States leads the world in this devastating epidemic. And the economic costs continue to rise, both directly and indirectly as a result of the ongoing drug epidemic. These costs impact every facet of our community and our economy. In addition, nearly 1/3 of children entering foster care do so in part because of parental drug abuse, which is overwhelmingly depressing. Many of the industries that our economy depends upon, such as construction, farming, manufacturing, and nonprofits, are being devastated by the drug epidemic. But you know, it's easy to feel overwhelmed from the daily reports of the negative consequences of the drug epidemic. For many of us, we feel helpless trying to comprehend this data on the growing rate of overdose deaths and incarcerations of our promising youth. Our innate clinical desire for meaningful intervention abuts against obstacles that feel so immense and so formidable that we become numb to the problem. We falsely believe it is someone else's problem to solve. These numbers don't really tell the full story. But sadly, the breadth and depth of this epidemic is so wide and so vast that all of us likely know someone who has suffered the negative consequences of drug, alcohol, and smoking use. If the numbers seem so large and overwhelming, then it is our job to think of these victims of substance use disorder individually and try to make a difference. It's like the old saying goes, how do you eat an elephant? One bite at a time. Every single individual we help through this will make a difference in the global approach and the United States approach to managing this epidemic. And as stated in rabbinical theology, he who saves a single soul saves the entire world. So why do people take drugs? For many, they do it because they simply want to feel better. They do it out of a curiosity. Sometimes they do it out of peer pressure. For many, they experiment with drugs as a way of self-medicating, treating paralyzing anxiety, overwhelming depression, and feelings of hopelessness, as well as to treat the painful symptoms of substance withdrawal. Factors that contribute to initial drug use, and for some, the development of addiction, are likely due to a combination of biological and environmental influences, the classic nature versus nurture. The impact of each of these factors, either individually or in combination, varies person to person. However, we do know that the younger one starts using drugs, the route of administration used to rapidly experience the drug's effects, and substance availability and cost are the primary contributors to developing addiction. When you look at the slide and looking at the environmental influences, it gives you a sense of things and ways that we can intervene to try to prevent the youth and adolescents from getting into addiction. Looking at economic issues, parental guidance and parental support, helping children do better in school. Studies have shown that students do better in school have a less likelihood of experimenting with drugs. Trying to intervene early on behavioral issues, aggressive behavioral issues, are all key aspects of trying to prevent addiction and recognizing this problem early. But in the end, a major reason people take drugs, drink alcohol, smoke cigarettes, or use marijuana is that they simply like what it does to the brain. When an individual first uses a substance, they often perceive what seems to be positive effects. They also believe they can control their use. But drugs can quickly take over a person's life. Over time, if drug use continues, other pleasurable activities become less pleasurable, and the person must take the drug simply to feel normal. They have a hard time controlling their need to use these substances, even though it causes many problems for themselves and their loved ones. Some people may start to feel the need to take some of a drug, or take more of a drug, or take it more often, or take it in combination with other drugs simply to control the highs and to manage the lows. These are all the signs of addiction. So how drugs affect the brain varies to some degree from person to person based on the substance use, frequency and amount of the drug used, comorbidities, and many other factors. In this graphic, endogenous release of a natural occurring brain opioid called endorphins stimulate the opioid receptors, resulting in a physiological release of dopamine. Exogenous use of opioids leads to an excessive stimulation and excessive release of dopamine. Pleasure or euphoria, the high from drugs, is still poorly understood, but likely involves surges of brain neurotransmitters, including endorphins and other transmitters such as serotonin in parts of the basal ganglia, which is the reward circuit. Dopamine likely has more to do with repeat pleasurable activities than with actually producing pleasurable activities. Nonetheless, large surges of dopamine teach the brain to work at the expense of other, more healthier goals and activities. So we know that several neurotransmitters are involved in the biochemistry of dependence and addiction. Each individual and their addiction is unique, and the same neurotransmitters may not be affected in each person. So a lot of what I'm discussing here is going to be more what I would call a generality. The primary neurotransmitters are serotonin, dopamine, acetylcholine, and glutamate, amongst many others. Each of these neurotransmitters has a unique role, and each conveys unique messages to the brain. For example, dopamine regulates the feelings of happiness, reward, and motivation. If levels of this neurotransmitter drops below 40 nanograms per deciliter, the individual will have a difficulty feeling any degree of pleasure or reward without the crutch of a drug or alcohol or marijuana or nicotine. At elevated levels, either through a rewarding experience or a substance use, a person feels high. This high is magnified when drugs such as cocaine, opioids, and methamphetamines are added to the mix. When individuals, and many individuals with substance use disorder, combine the use of drugs to enhance the high and downregulate the low. And that's why you see in this graph here, the more substances they add, the greater dopamine effect adds to that experience and leads eventually to some degree of addiction. The challenge is, with repeated drug use, a cycle of drug intoxication and then withdrawal develops. Over time, this interval gets shorter and shorter, requiring more and more drug just to maintain some degree of functional normalcy. Over time, the initial euphoria from drug use is replaced by the need to simply minimize the symptoms of withdrawal. In opioid withdrawal, for example, the symptoms experienced are opposite to the initial euphoria encountered. These symptoms include anxiety, panic attacks, and dysphoria. Drug craving results from the learned association between the relief of withdrawal symptoms and opioid drug taking. Even when an individual has not used an opioid for a period of time, relapse can be triggered by a craving induced by a memory that relief of anxiety and dysphoria were achieved injecting fentanyl. Simply returning to a location where a drug was used previously or seeing others use a drug is enough to trigger a craving, which ultimately leads in most people to reuse of the drug. So within days of repeated use, the euphoria of the drug use transitions into the addiction cycle. So in this example, I'm showing you really essentially what happens in the opioid addiction cycle. An individual injects, inhales, or smokes an opioid, a fentanyl, and they get this big surge in neurotransmitters, as I discussed previously, and you have incredible high, or you've minimized your withdrawal symptoms. But over time, your opioid levels drop, which means your neurotransmitter levels drop, and then your brain begins craving the opioids again, and this is where the addiction cycle occurs. This is a habit loop that can be applied, and the concept of this can be applied to any drug, any behavior, at any time. But you know, there are a lot of entities that we can blame for the epidemic. We can blame Big Pharma for falsely promoting the safe prescribing of opioids. We can point fingers at doctors who freely prescribe these addictive substances without considering their negative consequences. We can address the implications of the pain score and the requirement to document how we address pain so we could get a positive Press-Ganey score. Finally, we can blame patients who never seem to be satisfied for any attempt at pain control that did not seem to include the use of an opioid. Unfortunately, there is sufficient blame to go around. But it's equally easy and convenient to blame those suffering with addiction as being morally flawed and simply lacking in willpower. Those views shaped society's responses to drug use, treating it as a moral failing rather than a health problem, which led to the emphasis on punishment rather than prevention and treatment. As clinicians, we know that our patients benefit when we intervene and educate them about risk reduction while simultaneously managing their chronic illness and harmful choices. So instead of blaming and finger pointing, what if treatment became our priority? Are there benefits to treatment? Look what happens when someone stops smoking. Within weeks, they start feeling better, less mucus production. Their breathing eases. Their exercise tolerance improves. They simply start feeling better. They can start smelling. All of those great things that occurred before smoking tend to return once they stop smoking. The same can be said about quitting or markedly reducing one's alcohol consumption. Individuals experience more balanced moods, better sleep, and enjoyment of life. Initial brain changes from chronic alcohol use improve over time, leading to an enhanced quality of life. So the benefits of treating addiction: it saves lives. It helps it helps people move towards recovery and leading as a normal life as possible. It improves children's life chances, their chance to succeed in school, the chances to succeed in life. It reduces crime, and it prevents the spread of addiction. And much of that spread is when parents are using drugs and have addiction, there's a higher likelihood their children are going to have a similar addiction, and that's where this basically spread of addiction occurs. So, why does all this matter? It does because drug use is one of the most common causes of preventable death, injuries, and disability in this country. So to help solve a patient's problem, you first have to ask the right questions. Data from 26 showed that nearly 20 million adults who needed treatment for substance use disorder, only about 10 or 11% actually received the treatment. 2 million people, or 10%, received addiction treatment in the last 12 months. The point here is that if we don't ask about a problem, we don't identify a problem. If we don't identify a problem, then we cannot intervene, and we're only intervening on a small percent of people that truly are suffering from substance use disorder. It's the same with alcohol. About 38 million adults in the United States drink too much. That includes binge drinking, drinking heavily throughout the week, drinking during pregnancy. So it's a huge number of people that are either not reporting this to their clinicians, or more commonly, the clinicians are not asking about alcohol use, so these people are not being treated. Why screen for substance use disorder? Because 12% of U.S. residents aged 18 and over report unhealthy drug use. It's an insurmountable number. 5% of pregnant persons report unhealthy drug use in the past month. Nearly 60% of people aged 12 and over used tobacco, alcohol, or an illicit drug in the past month. We all know seeing the increased use of vaping as having a tremendous negative impact on youth. 22% of people or children aged 12 and over have binged on alcohol in the past month. So we screen because amongst the large population, we look at identifying someone who's either has a substance use disorder or is at risk of substance use and trying to funnel them into some degree of treatment. But at the end of the day, if you don't ask, the answer is always no. So screening, brief intervention, and refer to treatment, or SBIRT, is an evidence-based screening process developed many years ago to facilitate time and resource-sensitive interventions in acute care and outpatient settings. It has been shown to be effective in reducing alcohol consumption and consequences in unhealthy drinkers. Although this is widely endorsed, its implementation requires training, and the brief intervention step is usually restricted primarily to behavioral health treatment programs. SBIRT actually omits many FDA-approved medication therapies for the treatment of alcohol, tobacco, and opioid use disorder. The STIR strategy was introduced by Stephen Bernstein and Gail D'Onofrio in 2017 to add the initiation of pharmacotherapy during the index visit and then refer them on to treatment. So SBIRT is an evidence-based program for addressing risky substance use and is designed to be integrated into general medicine and other community health settings such as emergency departments, clinics, and dental practices. In population-based screening, everyone is screened, not just those who look like they have a substance use problem or report one. It is ideal for healthcare encounters, all encounters, which really are teachable moments when patients are more likely to listen and think about their health. The emphasis is on prevention, early detection, and early intervention. So the SBIRT process begins with a pre-screening stage, and if the pre-screening is positive, it moves to a full screening, and then based on the results of the full screen, we determine each individual risk, being mild, which maybe only requires brief intervention, moderate risk, which requires more intervention and counseling, to those in high risk that need more education, training, and often need to be referred to a substance use disorder program. So pre-screening provides the opportunity for early detection and intervention for risky substance use to prevent health problems and progression to substance abuse. It provides the opportunity to reinforce low-risk substance use. This quick intervention can help with medical management of individual cases when alcohol, drug, or tobacco use may be a factor. For example, very simple. You can ask the question, in the past 12 months, have you used drugs other than those required for medical reasons? How many times in the past year have you used a recreational drug or used a prescription medication for non-medical reasons? Full screening tools are administered after an individual has screened positive on a pre-screen or may be administered alone. Full screening tools ask a series of validated questions that assess the severity of an individual's substance use. Depending on the tool used, full screens can be administered as self-written self-reports or as part of a verbal interview. Here are some examples of tools created for the general adult population, as well as those developed and validated for specific populations such as adolescents, older adults, and pregnant persons. This is just a sampling of the many full screening tools that are out there that can be adapted to your own practice if you have the appropriate training. But in reality, at a minimum, the results of a pre-screen should be enough and can be enough to intervene and refer, especially in practices where training and resources are not available to do a full screen. So basically, if you pre-screen someone and they test positive or they mention that they have a problem with the substance use, you can still do an intervention, either mild or at best refer them onto a program to get them into the system. In the STIR process, a quick screening allows clinicians whose practice includes general healthcare and risk management to begin substance use disorder treatment in eligible patients. This includes partnering with community providers for ongoing care. This model was initially tested in the emergency department, but could be applied to other care settings fairly easily. Appropriately selected and screened individuals with specific substance use disorders such as opioid, alcohol, and nicotine can be offered clinically validated medications to treat withdrawal symptoms and control the cravings that makes abstinence so difficult to maintain. Fortunately, there are many available medication options that can be tailored to your patients. Regardless of your practice's approach to substance use disorder management, protocols for screening, medication eligibility, prescribing, management of withdrawal, and follow-up are always needed. General healthcare settings such as dentistry, wellness clinics, primary care, OBGYN practices, and emergency departments are the gatekeepers for the healthcare system. Healthcare encounters are often teachable moments when patients are more likely to listen and think about their health. Alcohol and drug misuse are major preventable causes for injury and disease. As clinicians, we are always in the right place at the right time to make a difference. Unfortunately, there are always excuses for not doing something that needs to be done. Putting off until tomorrow that you can do today misses an important opportunity to positively impact the public health crisis of substance use disorders. Your practice today may feel like it lacks the time or resources to make a difference, but substance use screening and referral only takes a few minutes. By enhancing your practice through a progression of small steps designed to impact the drug epidemic, you will become a role model for your staff and associates and become an influencer of others. To make an impact on the drug epidemic, we need to screen patients, provide a brief evidence-based intervention, address ways to reduce harm, and refer to treatment. In conclusion, substance use disorders typically begins in adolescence or early teen years. Substance use is a complex disorder with multiple influencing and contributing factors. Screening all patients for substance use increases the likelihood of identifying and positively intervening before addiction occurs. Regardless of your clinical practice, screening can be implemented with minimal costs or the need for additional resources. Thank you.